You know, when most of us think about going under general anesthesia, we usually just picture it as falling into a really deep sleep.
Right, like you count backward from 10, you hit maybe 8 or 7, and then the lights just go out.
Exactly. And the next thing you know, you're waking up in the recovery room. But what we don't realize is the sheer high-stakes physics experiment that begins the exact millisecond you lose consciousness.
Oh, absolutely. It's not just sleeping. We're talking about the exact moment a patient is fully anesthetized and, importantly, chemically paralyzed.
Right, because the brain literally stops sending that electrical signal down to the phrenic nerve. And the diaphragm, which is, your primary engine of respiration, it just goes completely slack.
Yeah, and in that instantaneous transition, your survival is handed entirely over to a clinician and a machine.
Yeah.
And it isn't just a simple switch of power.
It's not like turning off a battery and plugging into a wall outlet, right?
Not at all. Moving from spontaneous breathing to a mechanical ventilator is it's a fundamental, radical alteration of human physiology.
Which is exactly why we're doing this deep dive today. When you're breathing on your own, you're operating a negative pressure system.
Right, your diaphragm drops towards your abdomen, your chest cavity expands, and that intrapleural pressure drops. So air is essentially sucked into your lungs from the atmosphere.
Like a gentle vacuum. But a mechanical ventilator operates on the exact opposite physical principle. It forces air in under positive pressure.
Yeah, and the human body, just from an evolutionary standpoint, was not designed to have gas forcefully rammed down into its delicate, microscopic respiratory tree.
We are taking a system built for that gentle vacuum expansion and turning it into a pressurized inflation chamber.
It's a violent shift, physiologically speaking.
It really is. So our mission today is to elevate your understanding of that pressurized inflation chamber.
We've got a great stack of clinical sources today, too.
We really do. The literature we're examining dives deep into advanced respiratory mechanics, the mathematical modeling of the human breath, and the harsh realities of how lungs actually behave inside the operating room.
We want to move away from just, the rote memorization of dials and numbers on a ventilator screen.
Exactly. We want to build a profound grasp of the underlying physics. By the end of this deep dive, you will understand exactly why certain ventilator settings act as a protective shield for the lung tissue.
And conversely, why other settings can cause a silent, invisible, and potentially lethal injury while the patient is fast asleep.
Right. So before a clinician even touches the dials on a ventilator or, before they hook a patient up to the breathing circuit, they have to define the physical blueprint of the patient they're treating.
Because the physical properties of the lung tissue they're about to inflate literally dictate every subsequent decision.
Every patient's respiratory system provides a completely unique set of physical obstacles.
Yeah. When we push gas into the lungs, we're primarily dealing with two major opposing forces. The first is tissue stiffness, which in physiological terms we call elastance.
And the second is airway and tissue resistance, right?
Exactly. Those two forces govern everything that happens between the machine and the alveoli.
So let's break those down, starting with the static properties, compliance, and elastance.
Right. These describe the physical nature of the lung and the chest wall when air isn't actively flowing.
Right. Compliance is essentially the expandability of a structure. Mathematically, it's the change in volume per unit change in pressure.
So if a lung has high compliance, it expands very easily. A tiny amount of pressure gives you a massive change in volume.
But then elastance is the mathematical inverse of compliance.
Right. It's the tendency of a structure to snap back to its original resting shape after it's been deformed. It's the change in pressure per unit change in volume.
Meaning a lung with high elastance actively resists expansion.
Exactly. It requires an enormous amount of pressure to force even a really small volume of gas into it.
Now, I want to stop here and highlight a semantic trap, because this trips up almost everyone when they first study respiratory physics.
Oh, the rubber band thing.
Yes, the rubber band. In our everyday language, if I hand you a rubber band and say, wow, this is really elastic, what I usually mean is that it stretches really easily.
Right, you pull it, and it gives without much effort.
But in respiratory mechanics, high elastance actually means high stiffness. It actively resists being stretched.
Yeah, the linguistic flip seems totally counterintuitive until you look at the strict definition in physics.
So clarify that for us. Why does high elastance mean high stiffness?
Well, elasticity in physics is strictly defined as the physical property of a material that allows it to return to its original shape after being deformed.
Okay, so it's about the snapback, not the stretch.
Exactly. Think of a thick, heavy-duty rubber band like the kind you'd use to hold heavy industrial steel folders together. That has massive elasticity.
Because it's incredibly difficult to stretch out, right? It takes a lot of force.
Right, and the moment you release that force, it snaps back violently. Whereas a flimsy, cheap rubber band is highly compliant.
It stretches effortlessly, but it has very little elastic recoil. It barely snaps back.
Exactly. So in the human lung, high elastance means high resistance to deformation. The tissue desperately wants to stay small.
Okay, that makes perfect sense. So the second force opposing the ventilator is airway resistance, which only exists when gas is actually flowing.
Right, it's a dynamic process. The change in pressure divided by the flow rate gives us the resistance.
And sources say this is governed largely by the diameter of the airways, the total length of the respiratory tract, and the viscosity or density of the inhaled gas.
Yeah, we can visualize how these forces interact using a really classic respiratory analogy, inflating a balloon.
I love this analogy. Break it down for us.
So the narrowness of the balloon's neck represents the airway resistance.
Right, so a very narrow neck means you have to blow incredibly hard to force air through the opening.
Exactly, regardless of what the rest of the balloon looks like.
Right.
And then the rubber material of the balloon itself represents the elastance.
So if the balloon is made of thick, stiff, heavy-duty rubber, it has high elastance.
Yeah, and even if the neck is wide open, inflating it is going to be a massive struggle because the material itself refuses to yield.
Let's map this to actual clinical scenarios for the listener. Say a patient comes into the operating room with pulmonary fibrosis, which is characterized by severe scarring and thickening of the lung tissue.
That represents a scenario with extraordinarily high elastance.
Because the fibrotic lungs are exactly like that thick, heavy-duty rubber balloon.
Right. The ventilator has to generate remarkably high pressure just to deliver a totally normal tidal volume. The machine is fighting the sheer stiffness of the scarred tissue.
But then a disease like emphysema presents the exact opposite mechanical problem, doesn't it?
It does. The disease process literally destroys the elastic fibers of the lung parenchyma, so the patient has incredibly high compliance and abnormally low elastance.
Their lung is like a stretched-out floppy grocery bag.
That's a great way to put it. It takes almost no pressure to push air in, but because the lung has lost its elastic recoil, it doesn't snap back to push the air out during exhalation.
So the gas just gets trapped inside the chest, which leads to hyperinflation.
Exactly. So a clinician sitting at the head of the bed has to constantly evaluate this physical blueprint.
They have to assess the properties of the balloon's neck and the rubber material before doing anything else.
Right, because these properties determine the exact amount of energy the ventilator has to exert to move a volume of gas into the patient.
Which brings us to the mathematical heart of our deep dive today, the equation of motion.
Ah, yes. The equation of motion in respiratory mechanics is basically the foundational mathematical model of artificial ventilation.
It states that the total airway pressure, which we abbreviate as PAW, equals the elastic forces plus the resistive forces.
Plus any baseline pressure left in the lung, which we call PEEP, or positive end expiratory pressure.
The expanded formula from the clinical texts lays out the variables really clearly. It's PAW equals VT times ERS plus REAW times V dot dash I plus PEEP.
It sounds like a lot, but let's just dismantle this formula to see the mechanics in action.
Yeah, let's start with the first bracket, VT multiplied by ERS.
Okay, so VT is the tidal volume, which is just the actual size of the breath the machine is programmed to deliver.
And ERS is the elastance of the respiratory system.
Right, so multiplying the size of the breath by the stiffness of the lung gives you the exact pressure required purely to overcome the elastic recoil of the tissue.
Then the second bracket is RAW multiplied by V dot I.
Right, so RAW is airway resistance, which is governed by the narrowness of the endotracheal tube and the patient's own bronchi.
And V dot I is the inspiratory flow rate. That dictates how incredibly fast the machine is shoving the gas through those tubes.
Exactly. So multiplying resistance by flow rate yields the pressure required purely to overcome the friction of moving the gas.
And finally, we add PEEP to the whole thing.
Yeah, PEEP is the baseline pressure the ventilator continuously holds in the lungs, even when the patient is fully exhaled.
Just to keep the airways from totally collapsing shut, right?
Right. So adding the pressure to stretch the tissue, plus the pressure to push the air through the tubes, plus the baseline pressure holding things open that gives you the total airway pressure.
When I look at the equation of motion, it functions essentially like an itemized receipt from the ventilator for the total energy spent on a single breath.
Oh, I like that analogy.
Yeah.
The machine delivers the breath and basically hands the clinician the total bill.
Exactly. And looking closely at that receipt, the elastance tax is the energy spent physically stretching the chest wall and the stiff lung parenchyma.
And the resistance tax is the energy spent fighting the friction inside the narrow breathing tubes.
With the PEEP acting as the cover charge, the minimum baseline pressure required just to keep the alveoli open before the breath even begins.
That's a brilliant way to conceptualize it. And this receipt fundamentally calculates the work of breathing.
Because in basic physics, work equals pressure multiplied by volume, right?
Right. But the sources point out an even more crucial metric for modern mechanical ventilation, which is mechanical power.
And that's where time becomes a weapon, doesn't it?
It does. See, work is just the total energy deposited into the lung during one single breath. But mechanical power incorporates the temporal dimension.
Meaning it calculates the work applied to the lung per unit of time, which is measured in joules per minute.
Exactly. It factors in the respiratory rate and the inspiratory flow. It asks how rapidly and how frequently the machine is bombarding the delicate lung tissue with kinetic energy.
Because the goal of mechanical ventilation isn't just to force oxygen into the blood. The goal is to minimize that mechanical power.
Yeah, if the power output of the ventilator is too high, the machine is literally transferring destructive energy into the patient's microscopic cellular matrix with every single breath.
The tissue will eventually fail under that kind of assault.
You are risking ventilator-induced lung injury, which can trigger a systemic inflammatory response just as deadly as the surgical pathology the patient came in for.
You're turning a life-saving intervention into an engine of trauma.
That is the harsh reality of it, yeah.
Yeah. So we have the physical blueprint of compliance and resistance, and we have the mathematical receipt for a breath. But this equation undergoes a catastrophic disruption the exact moment the patient goes to sleep.
Right. The moment the brain stops driving the breath and the muscle relaxants take effect, the baseline state of the lungs is totally obliterated.
Let's contrast those two states. When a patient is awake and breathing spontaneously, the diaphragm is an active, tight, muscular dome.
It contracts downward toward the abdomen, generating negative pleural pressure that actively and uniformly pulls the dependent parts of the lungs open.
So the areas down near the bases of the lungs and the posterior chest are constantly expanded by this active downward traction.
Exactly. But under general anesthesia, particularly with neuromuscular blockade, that mechanism vanishes entirely.
The diaphragm is paralyzed, so the ventilator takes over, driving positive pressure down the airways from the mouth.
It's attempting to force the lungs open from the top down. And according to the sources, this sudden shift leads to a dramatic and almost immediate consequence.
The onset of atelectasis.
Right. Up to 20% of the normally aerated lung can collapse or become poorly aerated simply due to the induction of anesthesia.
That is wild. 1/5 of the lung mass essentially ceases to participate in gas exchange just from going to sleep.
Yeah, the primary culprit driving this massive collapse is a combination of compressive forces.
Like when the patient is lying supine on the operating table, gravity pulls the heavy, blood-filled heart and the anterior chest wall down onto the lungs.
More importantly, the paralyzed diaphragm experiences a cephalid shift.
Cephalid meaning moving toward the head. The diaphragm loses all its resting muscle tone and becomes a floppy, passive membrane.
And think about the abdominal organs. The liver, the stomach, the intestines, they are dense and heavy.
So without the taut diaphragm pushing back against them, the resting intra-abdominal pressure physically shoves the organs upward into the chest cavity.
Exactly, actively compressing the lower lobes of the lungs. And rib cage itself adds to the problem too. Well, in an awake individual, the intercostal muscles of the chest wall maintain an outward springiness, a resting tone that helps hold the rib cage expanded.
But when those muscles are chemically paralyzed, the chest wall literally caves inward slightly.
Right. This direct decrease in chest wall expansion, combined with the upward thrust of the abdominal organs, drastically reduces the functional residual capacity, or FRC.
Now, FRC is basically the volume of gas remaining in the lungs at the end of a normal, relaxed exhalation.
Yeah, it serves as the physiological safety buffer, the reservoir of oxygen that keeps the blood saturated while the body pauses between breaths.
And anesthesia inherently and immediately shrinks the FRC. The lungs get smaller, and the physical container of the chest cavity gets tighter.
And as the FRC drops and the alveoli get smaller, this really vicious cycle initiates at the microscopic level involving surface tension.
Which brings us to Laplace's equation. The texts bring up this 19th century mathematical theorem about soap bubbles to explain why human lungs collapse under anesthesia.
It's fascinating. Laplace's equation states that the pressure inside a spherical structure, like an alveolus, equals 2 times the surface tension divided by the radius of the sphere.
So P equals 2T over R. The mathematical reality is that the radius is in the denominator.
Right. As an alveolus gets smaller due to the shrinking FRC, its radius decreases.
Which means the pressure required to keep it open exponentially increases.
Exactly. A tiny bubble has a much higher internal pressure and wants to collapse onto itself much more violently than a large bubble.
Because the surface tension of the water molecules lining the inside of the alveolus acts like a microscopic rubber band constantly trying to pull the walls together.
So if the radius drops by half, the pressure required to hold the alveolus open literally doubles, assuming the surface tension remains completely static.
But thankfully, human biology has a built-in defense mechanism against Laplace's equation: pulmonary surfactant.
Yes, surfactant is incredible. It's a complex lipoprotein secreted by type 2 pneumocytes within the alveoli.
And its physiological purpose is to interfere with the hydrogen bonding of water molecules, thereby reducing surface tension, right?
Right. But the true structural genius of surfactant is its dynamic concentration.
What do you mean by dynamic concentration?
Well, as the alveolus shrinks and loses volume, the fixed number of surfactant molecules are packed closer together on the shrinking surface area.
Oh, I see. So this higher density of surfactant reduces the surface tension even further.
Exactly. It dynamically alters the variable T in Laplace's equation to protect against the shrinking radius R.
That's a brilliant biological design. But despite the brilliance of surfactant, when a patient is anesthetized, it's often not enough, is it?
It's not. Because with the diaphragm paralyzed and the abdominal organs shoved upward into the chest cavity, the radius of the dependent alveoli is reduced so drastically.
The dynamic concentration of surfactant just can no longer compensate. The surface tension overpowers the structural integrity of the air sac, and the alveolus snaps shut.
And that is the exact genesis of atelectasis. The functional residual capacity drops so low that the alveoli cross their critical closing volume.
And once they collapse, the opposing walls stick together.
Yeah, and because of the sheer physical force of surface tension, it requires a massive amount of positive pressure from the ventilator to pry them back open.
I want to paint a visual picture for the listener of what this looks like structurally inside the chest cavity of a patient who has just been intubated.
Go for it.
The chest cavity is basically a sealed vault. The floor of that vault, the diaphragm, normally acts as a tight trampoline that pulls downward, expanding the vault's volume.
Right.
But the moment the paralytic drug takes effect, that trampoline turns into a loose hammock.
A very loose hammock, yeah.
And the heavy organs of the abdomen resting beneath the hammock settle upwards, actively crushing into the bottom of the lungs.
So the lower lobes, which are normally the most well-ventilated areas due to gravity-dependent blood flow, are physically squished.
And the millions of tiny alveolar balloons in those lower lobes shrink until they hit their critical closing volume and pop shut. The functional volume of the vault has shrunk by a fifth.
But the terrifying part is that the ventilator does not inherently know that the vault has shrunk.
Right. It is programmed to push a set volume of gas into the lungs no matter what.
So that exact same volume is now being forcefully rammed into a much smaller, tighter space.
And the pressures inside the remaining open lung tissue begin to rapidly escalate.
Which is incredibly dangerous. And as if that physiological insult wasn't enough, the actual realities of the operating room environment compound the damage even further.
Oh, absolutely. The baseline loss of muscle tone is merely the starting line for respiratory deterioration. The specific demands of the surgical procedure actively assault whatever healthy lung mechanics remain.
The moment the surgeons require access and visibility, patient positioning becomes profoundly hostile to lung mechanics.
The sources focus intensely on the Trendelenburg position here. Let's talk about that.
Sure, so the Trendelenburg position involves tilting the entire operating table so that the patient's head is angled sharply down toward the floor.
With their feet elevated up in the air, it's ubiquitous in pelvic surgeries, gynecological procedures, and robotic prostatectomies.
And remember, gravity was already driving the anterior chest wall down when the patient was just lying supine. Now gravity acts along the longitudinal axis of the body.
Meaning the entire mass of the abdominal contents, already resting against that flaccid diaphragm, is now being actively driven by gravity straight into the thoracic cavity.
The cephalid shift of the diaphragm is magnified exponentially.
It's the equivalent of taking invisible, heavy sandbags and piling them directly onto the patient's fragile lung tissue.
Exactly. So the total respiratory system compliance absolutely plummets.
Returning to our balloon analogy, it is as if the balloon has been placed inside a rigid, heavy wooden box, and the ventilator is attempting to inflate it.
Right. The rubber of the balloon itself might be perfectly compliant and healthy, but the heavy chest wall and the crushing abdominal weight acting as the box absolutely refuse to yield.
And if the patient presents with significant obesity, the external weight of the chest wall is higher, and the mass of the abdominal contents is dramatically greater.
So the compressive forces crushing the alveoli are profoundly worse in those cases.
But then, surgical necessity pushes the boundaries even further during laparoscopic or robotic surgery.
Pneumoperitoneum is a massive challenge for the lungs.
Explain what that is for the listener.
To create a viewing space for the robotic cameras and instruments inside the abdomen, the surgical team pumps carbon dioxide directly into the peritoneal cavity.
They are actively pressurizing the abdomen to roughly 15 millimeters of mercury.
Right, so the anesthesia provider is now managing a patient with a paralyzed diaphragm, tilted head down in steep Trendelenburg, while the abdomen is inflated like a high-pressure tire.
Violently forcing the diaphragm even higher into the chest. The chest wall compliance basically approaches zero at that point.
The balloon is trapped in a tiny, pressurized, completely unyielding box.
So, as an anesthesia expert, how do you even justify this? The surgeon demands steep Trendelenburg and high abdominal pressure for visibility. They claim they cannot operate safely without it.
And they often can't.
Meanwhile, the anesthesia provider is sitting at the ventilator watching the airway resistance, and the tissue stiffness numbers soar into the danger zone. Why do you even let them do this?
Well, it is a high-wire negotiation, fraught with tension, I won't lie.
Where is the line between surgical visibility and permanent lung injury?
It's a delicate balance.
Mm-hmm.
The surgeon's visibility is paramount to preventing immediate, life-threatening complications, like uncontrolled hemorrhage or accidentally clipping a ureter.
So you have to accommodate them to keep the patient safe surgically.
Right. So the anesthesia provider must mathematically calculate the absolute minimum amount of positive pressure necessary to keep the lungs from completely collapsing under the weight of that pressurized abdomen.
But without pushing so hard that the ventilator ruptures the delicate alveoli that actually manage to remain open?
Exactly. It requires constant real-time adjustments to the flow rate, the tidal volume, and the inspiratory times.
You are threading the needle between surgical necessity and pulmonary destruction.
Every single minute of the case, yes. And adding another layer of complexity to this collapsing lung scenario is a phenomenon the texts describe as resorption atelectasis.
Right, this is fascinating. This involves a gas we reflexively consider to be purely beneficial oxygen.
We all love oxygen. Giving a patient 100% oxygen seems like a universal safety net.
But the sources explain that in the enclosed, pressurized physics of the lung, pure oxygen can actually be highly destructive.
It can. And the mechanism hinges on the physical speed of gas diffusion.
Okay, break that down. The ambient air we breathe is normally roughly 78% nitrogen and 21% oxygen.
Right, and nitrogen is the largely inert gas in human physiology. It does not cross rapidly from the alveoli into the pulmonary capillaries.
So it predominantly remains inside the air sacs, acting as a physical structural splint that holds the alveoli open.
Exactly. The nitrogen splint provides architectural support. But during the induction of anesthesia, the standard protocol is to pre-oxygenate the patient with 100% inspired oxygen.
Literally washing out all of that structural nitrogen.
Yes. So the alveoli become entirely filled with oxygen molecules instead.
And oxygen, unlike nitrogen, diffuses exceptionally fast into the pulmonary capillaries.
Because the body's actively consuming it, and the hemoglobin molecules in the blood act as this massive molecular sink, pulling it in.
So when areas of the lung become partially obstructed by the compressive forces of the abdominal organs or the surgical positioning,
fresh gas flows into those obstructed alveoli very slowly.
However, because that gas is pure oxygen, it diffuses out of the alveolus and into the bloodstream incredibly rapidly.
Right. The gas is leaving the microscopic balloon way faster than the ventilator can push it in through the partially narrowed airway.
So the volume of gas inside the alveolus drops precipitously, and the structure simply collapses inward on itself.
And that is resorption atelectasis.
The clinical application of high concentrations of inspired oxygen literally dissolves the internal structural support of the lung.
Accelerating the collapse that was already initiated by the paralysis and the positioning.
Wow. So to summarize where we have a significantly stiffer chest wall resulting from surgical positioning and obesity.
We have collapsed airways driven by the diaphragm shift, the loss of FRC, and resorption atelectasis.
The physical box surrounding our balloon is smaller and tighter than ever.
And the ventilator, completely lacking clinical judgment, simply registers that it must generate substantially higher pressure to deliver the programmed tidal volume.
But generating higher pressure is inherently dangerous. If the lung is trapped in this rigid box and the ventilator is stubbornly pushing the same volume of gas, the tissue is going to absorb immense physical stress.
Huge amounts of stress, yes.
So how does the clinician actually know when the lung tissue is on the verge of microscopic tearing? Is there a specific number on the screen that warns of impending injury?
The sources identify one critical marker above all others, and that is driving pressure.
Driving pressure. Let's really dig into this because it seems to be the most vital concept in understanding modern ventilator-induced lung injury.
It absolutely is. Driving pressure is defined mathematically as the change in lung volume above the functional residual capacity.
And how do you calculate it?
It is calculated by taking the plateau pressure and subtracting the PEEP, or by dividing the tidal volume by the compliance of the respiratory system.
So driving pressure is the amplitude of the stress. It is the exact amount of active, deforming physical force applied to the lung tissue with every single mechanical breath.
Yes, and the clinical literature is unequivocal on this point. Driving pressure is a staggeringly strong predictor of mortality in patients suffering from acute respiratory distress syndrome, or ARDS.
And the sources say it also strongly predicts the likelihood of postoperative pulmonary complications in normal surgical patients, right?
It does, because the magnitude of the stretch is what causes the damage.
So differentiating between peak airway pressure and plateau pressure on the ventilator screen is crucial to isolating this variable.
Highly crucial. Peak airway pressure is the absolute highest pressure registered during the entire inhalation cycle.
It represents the total summative force required to overcome both the flow resistance of the endotracheal tube and the airways, plus the elastance of the lung parenchyma itself.
Returning to our physical analogy, peak pressure is the total force required to violently shove the gas through the narrow neck of the balloon and simultaneously start stretching the thick rubber material.
Right. So if the patient has an asthma attack, causing the bronchi to tightly spasm, or if the endotracheal tube is kinked, the peak pressure will immediately skyrocket.
Because the airway resistance just spiked massively.
But the actual lung tissue deep in the chest might not be experiencing that dangerous pressure, right?
Exactly. The kinetic energy is mostly being dissipated, fighting the friction of the narrow tube.
So plateau pressure isolates the true stress on the actual lung tissue.
Right. It is measured by commanding the ventilator to initiate an end inspiratory pause, holding the breath in the lungs for roughly 3 seconds.
Okay, so during that 3-second pause, the flow of gas comes to a complete stop.
And because flow is zero, the airway resistance variable drops out of the equation of motion entirely. The flow multiplied by resistance equals zero.
So what remains on the screen is the pure, static, elastic recoil pressure of the alveolar tissue, and that is the plateau pressure.
Exactly. Peak pressure fights the neck of the balloon. Plateau pressure is the active force stretching the rubber material at the end of the breath.
And driving pressure is simply that plateau pressure minus the baseline PEEP. It isolates the pure cyclical deformation of the tissue.
You've got it perfectly.
So explain to the listener why it is this specific stretch, the driving pressure, that causes ventilator-induced lung injury, while the high flow resistance of the peak pressure is generally tolerated.
Well, high airway resistance forces are mostly absorbed by the large, tough, cartilaginous airways, like the trachea and the main stem bronchi.
Their structural integrity is immense.
Right. But the alveoli, which are the actual functional gas-exchanging units at the end of the respiratory tree, are unimaginably delicate.
The sources mention they are constructed of a layer of cells only 1 cell thick.
Yes, the type I pneumocytes. So when a patient is subjected to high driving pressure, the ventilator is forcing these delicate microscopic cells to stretch violently from their resting state.
And then rapidly recoil, repeating this cycle perhaps 15 to 20 times a minute.
Right, and this massive, repetitive cyclical stretching induces profound biomechanical shear stress.
it physically overloads the cellular scaffolding, right? It tears apart the tight junctions that bind the pneumocytes together.
It does. And ripping those tight junctions opens the floodgates between the vascular system and the air spaces.
Once the cellular barrier tears, plasma and inflammatory fluid from the surrounding pulmonary capillaries flood directly into the alveoli.
Which is a disaster, because the body detects the structural failure and triggers a massive inflammatory cascade.
White blood cells rush into the lung tissue, releasing destructive cytokines. The lungs fill with fluid, cellular debris, and eventually dense scar tissue.
The biomechanical injury of excessive stretching has literally initiated ARDS.
Which connects directly back to the dangers of atelectasis we discussed earlier.
It does, in a very dangerous way.
If 20% of the lung collapsed during the induction of anesthesia, the remaining 80% of the open alveoli are now forced to accept the entirety of the ventilator's programmed tidal volume.
Right, because the gas cannot enter the collapsed areas, so it takes the path of least resistance directly into the remaining open tissue.
So the functional lung is massively overdistended. The driving pressure applied to those specific, open, supposedly healthy areas of the lung is exponentially amplified.
They are bearing the burden of the entire breath. In severe pathology, we actually refer to this as the baby lung concept.
The baby lung concept, tell us about that.
Well, a patient may have the physical chest cavity of a large adult, but because of extensive atelectasis, the actual volume of aerated lung participating in gas exchange is only the size of a baby's lung.
Wow. So delivering a standard adult tidal volume into a baby-sized lung
Delivers a localized hurricane of kinetic energy to a tiny fraction of open alveoli, tearing them apart with catastrophic driving pressure.
The lung is trapped in the danger zone, suffering microscopic biomechanical failure, and the clinician cannot simply shut the ventilator off, obviously.
No, the patient requires oxygen to survive the surgery.
So the clinician must safely manipulate the ventilator's physics to protect the cellular matrix while maintaining gas exchange.
Yes, and historically, the standard clinical dogma for doing this was remarkably simplistic. Just lower the tidal volume.
Give smaller breaths. I mean, it makes intuitive sense. If the mechanical stretch is causing the tearing, logically, stretching it less should solve the problem.
And to be fair, lowering the tidal volume did revolutionize critical care, but the clinical sources we're reviewing highlight a profound nuance to this.
Right. Adjusting the tidal volume is not a universal physiological fix.
It's not. It must be intimately scaled to the patient's actual functional lung size, their FRC.
The literature actually demonstrates that if a patient has highly compliant lungs, meaning their balloon is large, stretchy, and not significantly collapsed, and their driving pressures are already registering in a safe low range.
Aggressively lowering the tidal volume even further in those patients can actually inflict significant harm.
The data indicates that lowering the tidal volume to 6 milliliters per kilogram of ideal body weight or less in these specific highly compliant patients can actively increase mortality.
Which sounds totally backwards, right? A smaller, theoretically safer breath causing fatal complications seems paradoxical.
So where does the harm stem from?
It stems from two distinct mechanisms: ventilator desynchrony and the promotion of atelectasis.
Let's start with this synchrony.
Okay, if a clinician programs a breath size that is severely mismatched to the patient's actual lung capacity and metabolic demand, the patient will experience profound air hunger.
So if they are not under complete chemical paralysis, say they are waking up from anesthesia or on a lighter sedation drip, their brainstem will violently fight the machine.
Exactly. The diaphragm contracts with immense force, attempting to pull a huge breath, but the ventilator valve is closed because it has already delivered its tiny programmed volume.
So the patient is essentially sucking forcefully against a blocked tube.
And this generates massive, chaotic, negative pressure swings inside the thoracic cavity.
The sheer stress from the dysynchrony tears the lung tissue, and the profound negative pressure literally sucks fluid out of the capillaries and into the alveoli,
Causing negative pressure pulmonary edema.
That sounds horrific. And the second mechanism was promoting atelectasis.
Right. If the tidal volume is chronically set too low, the ventilator is not generating enough intermittent positive pressure to keep the smaller terminal airways structurally splinted open during the respiratory cycle.
So the low volume actively encourages the dependent portions of the lung to gradually collapse back down,
Worsening the very atelectasis the clinician is attempting to avoid in the first place.
So lower is not universally better. The volume must precisely match the size of the open participating lung.
Exactly. And to match that volume and keep the lung open, clinicians rely heavily on manipulating PEEP and employing recruitment maneuvers.
This is the direct physical counterattack against the atelectasis driven by surgical positioning, obesity, and paralysis.
It is. A recruitment maneuver is the intentional, temporary application of severely elevated airway pressure.
The clinician is essentially executing a sustained, highly pressurized sigh for the patient.
Right. They might close the adjustable pressure limiting valve and hold 30 or 40 centimeters of water pressure inside the lungs for 20 to 30 seconds.
The mathematical goal being to overpower the critical opening pressure dictated by Laplace's law and physically pry the collapsed alveoli back open.
Yes, but reinflating the crushed lower lobes of the lung carries massive systemic consequences.
Because holding 40 centimeters of pressure inside the thoracic cavity for 30 seconds doesn't just affect the alveoli, does it?
Not at all. The extreme intrathoracic pressure physically crushes the superior and inferior vena cava.
Meaning venous blood cannot return to the right side of the heart.
Exactly. Cardiac output plummets, and the patient's blood pressure crashes dramatically.
So the clinician is trading transient cardiovascular collapse for the restoration of lung volume.
It is a calculated risk, one that requires intense vigilance. And once the alveoli are successfully recruited and popped open, the clinician cannot simply drop the baseline pressure back to zero.
Right, because Laplace's law dictates that the alveoli will immediately snap shut again due to surface tension.
So the baseline PPA must be aggressively increased to a level sufficient to splint the newly opened tissue permanently.
The clinician is artificially restoring the functional residual capacity that the anesthesia and the surgeon stripped away.
Exactly. They're establishing a safe, positive transpulmonary pressure gradient.
To visualize this delicate optimization process, the clinical texts rely heavily on something called the compliance curve.
The compliance curve is fundamental. It is an S-shaped graphical representation mapping the pressure applied to the respiratory system on the x-axis against the resulting volume on the y-axis.
And this curve essentially dictates the boundaries of safe ventilation.
It does. At the extreme bottom of the S-shape, the curve is nearly horizontal.
This is the zone of dense atelectasis, right? The ventilator is applying increasing pressure, but the volume is barely changing because the collapsed alveoli are stubbornly refusing to yield.
Right. The clinician is basically pushing against a locked door.
But as the pressure continues to rise, it hits a specific mathematical threshold known as the lower inflection point.
Yes, and at this precise pressure, the collapsed alveoli suddenly succumb and pop open.
And the curve instantly shoots upward at a steep angle.
Exactly. This steep middle section of the S-curve represents the zone of normal, healthy lung mechanics.
The compliance is excellent here. A tiny application of pressure yields a massive, healthy delivery of volume.
The physiological goal is to trap the patient's entire breathing cycle within that steep middle section.
But the curve inevitably flattens out again at the top, doesn't it?
It does, and this is the upper inflection point.
The lung tissue has been stretched to its absolute physical maximum. Applying additional pressure in this zone generates almost no additional volume.
It solely generates massive amounts of destructive driving pressure, leading to gross barotrauma and the microscopic tearing of the cellular matrix we talked about.
So the entire strategy of lung protective ventilation is defined by strictly utilizing PEEP to keep the baseline pressure above the lower inflection point, preventing cyclical collapse.
And restricting the tidal volume to ensure the peak inflation never crosses the upper inflection point, preventing overdistension.
It's like finding a Goldilocks zone. But executing this strategy in the operating room is not a static process, is it? You can't just set the dials at the beginning of a 6-hour procedure and walk away.
Oh, absolutely not. It is a highly dynamic, continuous analytical loop.
Because the surgical demands change. The patient is tilted into steeper Trendelenburg, the carbon dioxide insufflation pressure fluctuates, and the chemical paralysis slowly wears off.
Exactly. The clinician must constantly interrogate the dynamic waveform scrolling across the ventilator screen.
The flow volume loops and the pressure time tracings provide real-time feedback on the physical state of the tissue.
Right. For instance, if the pressure tracing suddenly spikes into a sharp, beak-like peak at the very end of every single breath,
the lung is signaling that it has hit the upper inflection point. The tissue is physically maxed out.
and that specific visual cue mandates an immediate reduction in the tidal volume.
Conversely, what if the driving pressure begins to slowly, insidiously creep upward over the course of an hour, even though the tidal volume setting hasn't been touched?
Then the underlying physics of the chest have altered. The lung is becoming stiffer.
Alveolus by alveolus, the tissue is silently collapsing. Atelectasis is creeping back into the dependent lobes.
Exactly, and that creeping number is the signal to execute another hemodynamically costly recruitment maneuver and dial up the PEEP to recapture the lost functional capacity.
The clinician is engaging in a continuous, millimeter-by-millimeter physiological war against gravity, surface tension, and surgical compression.
They are constantly reevaluating the equation of motion with every breath.
Moving a patient from spontaneous breathing to a mechanical ventilator fundamentally violently alters the physics of their existence.
It really does. The invisible forces of elastance and resistance dictate every breath.
The mathematics of the equation of motion calculate the exact kinetic energy deposited into the cellular matrix.
While the chemical paralysis of the diaphragm and the crushing external pressures of surgical positioning conspire to collapse the functional volume of the lung.
And the critical threshold of driving pressure serves as the ultimate marker of impending mechanical failure and inflammatory disaster.
By mastering these concepts, the clinician stops merely operating a machine and begins actively protecting the architecture of the human lung.
Understanding the physics transforms the cryptic numbers on a ventilator screen into a vivid, real-time narrative of what the lung tissue is actually enduring.
It's the foundation of high-level critical care.
It really is. To you, the listener, navigating this complex material, mastering the mechanics of the airway is absolutely vital. We have explored the deep mathematical and physiological structures that dictate survival under anesthesia.
But there's always more on the horizon, isn't there?
Always. Before we conclude, consider a concept that pushes the boundaries of everything we have discussed regarding the danger of overdistension and the necessity of targeted recruitment.
Right now, clinical practice relies heavily on measuring driving pressure based on the global compliance of the entire respiratory system.
The ventilator provides a single pressure number representing the entire thoracic cavity.
Yet, as we have established, the diseased or anesthetized lung is profoundly heterogeneous.
The dependent lower lobes are entirely collapsed under the weight of the abdomen, while the anterior upper lobes are wide open and compliant.
So that global number is really just an average that masks the localized destruction occurring in different regions of the lung.
Imagine a future where clinicians are no longer flying blind with a single global average. Technologies like electrical impedance tomography use a belt of electrodes around the patient's chest to measure the real-time resistance to microcurrents passing through the tissue.
Because air has a different electrical impedance than fluid or a collapsed tissue, right?
Exactly. So this technology can generate a continuous, dynamic visual map of the lungs. It calculates the specific regional driving pressures across different anatomical segments, millisecond by millisecond.
That would be incredible if a ventilator could integrate that electrical impedance map.
Delivering anatomically targeted mechanical ventilation that actively senses which specific millimeter of lung is collapsing and which is overdistended. How would that fundamentally alter the survival rate in the operating room?
It would completely change the game.
Think about how the physics of the breath will evolve. Keep diving deep.